Rheumatology. So in rheumatology, what is this? That leg is shortened, isn't it? That leg is shortened and it's externally rotated. The left leg is shortened and externally rotated. That's what happens when you have a hip fracture. When you have a hip fracture, leg shortens and pulls out. Shortens and pulls out. When you have a hip fracture, leg shortens and pulls out. That's a hip fracture. So you do an x-ray of the hip as it shortens and pulls out, and a surgical repair. That's it. Shortened and externally rotated. This is a bigger deal than you might think if you've ever, or someday when you notice that it's been missed by somebody, and you actually find grandma's in the bed, and oh, she's just lying around with her leg up. What's happened? Missed hip fracture? Yes, it's true. Shortened and externally rotated. Now what's this? So what's the issue? Is one small or is one big? Is this one abnormally small or is this one abnormally big? Maybe it's a right-handed person that's in a Greek fraternity. What was that Greek fraternity? I'm a masturbator? Well, it's not this one. This is the normal. The abnormal one is the one on the top, on the left. The one on the top, the left hand, is thenar wasting. Ooh, see that there? That thumb? That's normal. That thumb is abnormally small. Abnormally small. Wasting of the thenar or thumb-ar eminence. In other words, that should be big and beefy. Okay? And that person's thenar eminence was thin. Because the abductor pollicus brevis and the flexor pollicus brevis are thin. They're thin. This is carpal tunnel syndrome. Carpal tunnel syndrome makes those muscles not work. They're not innervated. So you tap, tap, tap with tells, and sends vibration. I can tell, and I feel my vibration, and it makes me sick. And what ends up happening, yes, bless you too, my son. Okay, so median eminence damage from carpal tunnel syndrome damages the thenar eminence and it gets thinner. And when you tap, 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 it reproduces the symptoms because you're tapping on the nerve. Phalanx is one of my best ones to do as a group. Let's all do this together. Ready? Phalanx. And Phalanx sign is you're pressing against the carpal tunnel. The flexor retinaculum gets pressed against the carpal tunnel. And this is also a sign of carpal tunnel syndrome. Tinel's is when you tap on it, and Phalanx is when you squeeze it. Now, the most accurate test, very rarely needed, is electromyography. You want to see if the nerve has been compressed? Electromyography sees if the nerve's been compressed. That's the most accurate of those tests to see if the nerve is being compressed. Not necessary most of the time, but it is the most accurate of those tests. Now, those tests that you're not supposed to do is an MRI. The test that you're not supposed to do is a CT scan. The test that you're not supposed to do is imaging tests. And that's going to be the most common wrong answer. Imaging tests of the wrists are wrong because even if you see narrowing, it doesn't mean there's a functional abnormality. If you see no narrowing, there might be a functional abnormality. Physical narrowing is not as important as functional impairment. And that's why an MRI of the wrist is not as important as saying, do you feel numbness and tingling in those fingers when I tap on you? Do you have wasting of the thenar thumb-ar eminence? Is it sparing the other side of the hand and just here? That functional abnormality is far more important. That functional abnormality is far more important than seeing a physical narrowing. Which of these is which? Let's see. Okay, what do you see on the left? What do you see on the right? What do you see on the left is Bouchard's nodes. What do you see on the right? These are Heberden's nodes. These are outcropping of the distal interphalangeal joints. So on the left, you see Bouchard's nodes. Bouchard's nodes. And on the right is Heberden's nodes. Therefore, what we're seeing here is osteoarthritis. These are both findings of osteoarthritis, except that Bouchard's is on the proximal interphalangeal joint and Heberden's is on the distal interphalangeal joint. And you don't change therapy. They are just osteophytes. They don't interfere with functioning. Bouchard's is more proximal and Heberden's is more distal. But since they don't interfere with functioning, you don't have to do anything about them because they're not changing the functioning of the hands. Bouchard's proximal, Heberden's distal. What do you see? 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 What is that? Nail pitting, nail pitting. What do you see? What do you see? What do you see? Nail pitting, nail pitting. Nail pitting. This is nail pitting, and we're in the rheumatology section. And nail pitting in the rheumatology section is... it is psoriatic arthritis. So psoriatic arthritis is one of the seronegative spondyloarthropathies. Ankylosing spondylitis, reactive arthritis, CNP of Reiter syndrome, CNP of Reiter syndrome, psoriatic arthritis. There's no blood test. That's why it's called seronegative. No rheumatoid factor because it's called seronegative. And you see on the tests, you see that there is, blood tests are all negative, and although the SED rate is a little elevated, yeah, so what? It's not always elevated, and it doesn't mean anything, even if the SED rate's a little up. So what? So the X-ray will show pencil and cup deformity. Yeah, because it becomes narrowed down to a point. The X-ray will show a pencil and a cup deformity as it becomes narrowed down to a point. And no specific therapy exactly reverses it, but methotrexate can be used to stop progression. So there's a difference between saying reverse, nothing reverses it. Prevents progression, methotrexate. Methotrexate is good for the distal skeleton like that because psoriatic arthritis. What do you need to know about it? Seronegative, nail pitting, pencil and cup deformity of the bones that come down to a narrowed point, and methotrexate. And you'd only use TNF inhibitors if the methotrexate does not work. So infliximab, adalimumab, etanercept, infliximab, adalimumab, etanercept are tumor necrosis factor inhibitors, and these are only used if methotrexate does not work. Psoriatic arthritis. Next one. Look at those knees. Lord, really, really, Lord. They're not my favorite sort of knees. They'll have to look at those knees. Oh, come on. Look at the knees. Is the one on the left abnormally large, or is the one on the right abnormally small? Where's the defect here? And the answer is that the disease that this is an effusion on the, well, our left, the patient's right leg, our left, the patient, that's an effusion. This needs to be tapped. That's an effusion, needs to be tapped. Is it blood? Is it infection? I can't tell. I can't tell if there's blood or infection there. I can't tell if there's blood or infection until after I put a needle in it. Can the X-ray tell you blood or infection? No. The X-ray cannot tell you blood or infection. The X-ray cannot tell you blood and infection. Infectious arthritis from staphylococcus, gout, trauma, you can't tell until you put a needle into it and you see the blood. Until you put a needle in it and you see negative needles. Until you put a needle in it and you see white count of 100,000. So any inflammatory disorder can cause a joint effusion, and sometimes you need to be able to tap the joint because sometimes if you can't at the beginning tell you what it's from, so rheumatoid arthritis rarely needs to be tapped because it's got a definition of chronic joint stiffness, okay, multiple joints going on for an hour in the morning, going on for months and months, rheumatoid arthritis. But arthrocentesis to tell you for specifically for a knee effusion is by far the most accurate test. 100,000 white cells, it's infection. Negative needles, it is gout. Positive rhomboid-shaped crystals, it is pseudo-gout or calcium pyrophosphate deposition disease. Rheumatoid arthritis, which not so much that there's anything specific on a tap for rheumatoid arthritis, it's more that you tap the joint to exclude gout, pseudo-gout infection. That's why you tap the joint in rheumatoid arthritis. Tenosynovitis is inflammation of the tendon sheaths. When you move the tendons, it hurts. Tenosynovitis is inflammation of the tendon sheaths. And when you move them, they hurt. And when you have certain infections, like disseminated gonorrhea, you get tenosynovitis from disseminated gonorrhea. The treatment for tenosynovitis is to correct the underlying cause, or anti-inflammatories. So inflammation of the tendon sheaths of the hands and feet. Now, this is important because if you have disseminated gonorrhea, gonorrhea is a very difficult organism to diagnose. So what you end up having to do is you say polyarticular, tenosynovitis, and petechial rash. Polyarticular, tenosynovitis, and petechial rash tells us it's disseminated gonorrhea. And you have pain with the use of the hand with grasping or pinching on movement. Pain with the use of the hand on grasping, pinching, or movement. And because anything that makes it moves, okay, it's tendinitis. Okay? Tenosynovitis. So when tenosynovitis is associated with petechial rash, joint pain, there's your diagnosis. And the reason why this is really important is that disseminated gonorrhea, first of all, it doesn't grow in blood culture but 10% of the time. Second, it doesn't even grow in the joint fluid culture half the time. So in order to diagnose that disseminated gonorrhea, you need tenosynovitis, petechial rash, polyarticular. Yeah? And when it's caused here, you just anti-inflammatories. Anti-inflammatories because it decreases the inflammation. Yes, you're treating the gonorrhea with antibiotics, but the tenosynovitis as an inflammation gets better right away with non-steroidals. The gonorrhea gets antibiotics like ceftriaxone. The gonorrhea gets antibiotics like ceftriaxone. The gonorrhea gets the antibiotics, but the tenosynovitis, non-steroidals. Tenell's sign just means tapping. Don't you wish that you were Tenell? Every time somebody's like, you know, tap that joint, bang, you say, that's my sign, Tenell's sign. Oh, Tenell's sign is produced every time there's entrapment or compression. Okay, when anything that is entrapment and compression or narrowing, like carpal tunnel syndrome. So any tapping of a narrowed, compressed nerve reproduces the symptoms. A little percussion on the flexor retinaculum, and you say, hey, I've got an abnormality there. That means I've got compression, so that I know that I need splints, 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 splints. And if splints and immobility don't help, and steroid injections don't help, and if splints and immobility don't help, and steroid injections don't help, we got to cut the flexor retinaculum. Okay, because this is telling you've got sensory abnormalities in that median nerve. That's all just positive. Remember, Phelan's, Tenell's. Tenell's means that tapping. Almost down to the end here. What do we got? Oh, look at that. You see, this is 3 different ways of representing the ulnar deviation of rheumatoid arthritis. Rheumatoid arthritis gives ulnar. This is a very unusual finding in the modern world. We should almost never be seeing this anymore, because we should be giving methotrexate and TNF inhibitors so no one ever gets deformed like this. What is shown here is ulnar deviation. The diagnostic test, you can't just say, well, you know, we have joint pain. There are diagnostic tests for rheumatoid arthritis. Rheumatoid arthritis always has a blood test. Is it rheumatoid factor or cyclic citrullonated peptide? One or the other. Rheumatoid factor or cyclic citrullonated peptide. Oh, is it a SED rate or a C-reactive protein? Rheumatoid arthritis is not rheumatoid arthritis without an abnormal blood test. The therapy for rheumatoid arthritis is methotrexate to stop progression. As soon as you know it's rheumatoid arthritis, we're giving methotrexate to modify the disease. Rheumatoid arthritis, this is ulnar deviation. We're giving the TNF inhibitors and the methotrexate to prevent that thing from ever happening. You should never be having that sort of horrible deformity again. That's never supposed to be happening again, where you have this sort of diagnosis. So it's not a single test that diagnoses it. In other words, if you had a cyclic citrullonated peptide, but you didn't have morning stiffness going on for months, sedimentation rate, you just had a cyclic citrullonated peptide alone, it wouldn't be rheumatoid arthritis. To be rheumatoid arthritis, you have to have multiple things. Morning stiffness, multiple joints. Nodules are not necessary, but they're suggestive. Rheumatoid factor or cyclic citrullonated peptide. But one thing alone can't diagnose rheumatoid arthritis. One thing alone does not diagnose RA. Multiple joints, long duration of stiffness, long duration of disease, SED rate or C-reactive protein, rheumatoid factor or cyclic citrullonated peptide. That's all a mouthful, isn't it? Once you make the diagnosis, you go straight on to a disease-modifying drug. When we say non-steroidals are the initial therapy, we mean the first thing for pain. But non-steroidals don't modify anything except your gastric lining when it burns holes in that gastric lining. Methotrexate works well for that distal skeleton. Methotrexate does not work well for the axial skeleton. The axial skeleton is the spine and the sacroiliac joints. The spine and the sacroiliac joints. So methotrexate does not work well for the axial skeleton, which is the spine and the sacroiliac joints. So methotrexate works for more distal joints like the rheumatoid arthritis joints. And if that doesn't work, tumor necrosis factor inhibitors will stop the progression. It's a wonderful time to be a rheumatologist.